Hello everyone. Welcome to the March edition of DNA Dialogue, a virtual forum to learn of new developments in health genomics and engage with global experts in the field. I'm Tiff Bortwood. I'm the Managing Director of Australian Genomics. As we come together today in the spirit of reconciliation, I acknowledge the traditional custodians of country throughout Australia, excuse me, and their connections to land, sea and community. I'm joining you from the lands of the Boonwurrung people of the Kulin Nation, and I extend my respects to their elders past and present, and also extend that respect to Aboriginal and Torres Strait Islander people joining this call today. If you have questions during the talk today, please use the Q&A function during the presentation, and we'll do our best to get to as many of your questions as we can after the presentation. If you're active on social media, we'd be grateful if you would hashtag DNA Dialogue and also tag @AusGenomics. So it's my very great pleasure today to introduce a friend, Kym Boycott, Professor Kym Boycott, who is Professor of Paediatrics at the University of Ottawa in Canada, where she's a clinical geneticist at the Children's Hospital of Eastern Ontario, or CHEO. She's the chair of the Department of Genetics, senior scientist at the CHEO Research Institute, and holds Tier 1 Canada Research Chair in Rare Disease Precision Health. She leads the National Care for Rare Canadian Consortium, Rare Disease Models and Mechanisms Network, that is sort of the inspiration for the AFGN in Australia, and she also chairs the All for One Precision Health Initiative that integrates genomic, other omics, data sharing and model systems to improve our understanding of rare disease. She's also one of my favourite people to catch up with at conferences. So today, Kym will be sharing a presentation with us entitled Harnessing AI for the Early Identification of Patients with Undiagnosed Rare Genetic Diseases. Kym, welcome. Thank you so much for joining us.
Thank you, Tiff. All right. Well, thank you very much, everyone, for inviting me to be part of this, what looks like an amazing series. And the timing works pretty well, too. It's 6 o'clock at night here. It's still light out. And I look forward to spending the next hour with you or so. As Tiff mentioned, I'm going to speak to you today about an algorithm we've developed that identifies potentially undiagnosed rare genetic disease patients. And my ThinkRare team, part of them are here today. Ivan Tarakoff, Alex White-Brown, and Caitlin Chisholm, who will be providing backup for me for any questions that relate to some of the machine learning and things like that may be out of my scope. And the other thing I want to say is, too, that I'm speaking from Ottawa in Canada, and I live and work on unceded Algonquin Anishinaabe territory. And we at CHEO, my institution, honor all First Nations, Métis, and Inuit peoples and their valuable past and present contributions to this land. So just to pitch where this is coming from, we have been very interested as part of the Care for Rare Canada Consortium for the last 15 years on precision diagnostics for rare genetic disease. And we've had, many, many national collaborative grants over this 15 years to help really do two things. The first, where we spent a lot of our time, is understanding the mechanism of all the potentially undiagnosed rare diseases. And you can see to the right there that we've, initially focused very much on the coding, but in the last sort of 4 to 5 years and going forward in our next project called Care for Rare Expand, we will be focusing on things underneath the water at the bottom of the iceberg. While we've been doing this, we also very much have started to pay attention to access. And so initially our access was really focused on building the clinical utility and value for money type data, real world data for Canada, to ensure that the genome-wide sequencing, exome genome sequencing, other sorts of new genetic technologies are reimbursed, and that patients can kind of have access to them to ensure a timely diagnosis in their care pathway. But what we really began to recognize, and certainly this is what we hear from the patient organizations, is that access to this type of testing is linked to visibility. And you can see there on the right that there are all kinds of reasons that even though patients are living in a very developed country like Canada or Australia, with quite a reasonably a good healthcare system, they sometimes can still have issues with access due to many factors, including the fact that they may not be recognized in the healthcare system as potentially having a rare genetic disease. We estimate that about 1 in 50 Canadians are affected with a rare genetic disease. And when we use that number, we really are talking about those Canadians that are affected by a change in a single gene or in a set of genes, like in a microdeletion syndrome, not so much in our, risk factors and other sorts of things like that. So when you can look at over on the right at all the various challenges, there can be many reasons why these patients sort of can get lost in the system, even within a system such as ours. So we asked the question, how can technology assist in the diagnostic process? And so we want to be able to identify eligible patients who need, sophisticated, comprehensive genetic testing to enable their precision diagnostics early in their diagnostic trajectory. And we and others have begun to think about how all of this electronic data we now have, machine learning and AI can help with this. And so there have been examples in the literature of how artificial intelligence or machine learning has supported clinical decision-making. And you can see a couple of examples there. Most of the examples in the literature really have focused on a very specific disease, such as cardiac amyloidosis or porphyria or lipodystrophy example that we have there, where they are using very deep phenotyping knowledge from the electronic health record to identify a single disease. And often these patients are being identified in this fashion because there is disease altering treatment that is available, and so being missed is a big deal. So what I want to talk to you about today, though, is how we took a bit of a different approach to this. So I'll talk about these 4 things. I'll start with the background and data infrastructure at my institution in Ottawa called CHIO. So first of all, this is CHIO. You can see on the very far right, that's a photo of CHIO, and I picked this one off the internet because it shows that there are no leaves and some snow on the ground, so it very much reflects today. And over on the left, you can see where Ottawa is in Canada. So we live in the province of Ontario and right beside Quebec. And so we serve a catchment area of 500,000 children. They are from the eastern area of Ontario, western Quebec, Nunavut, which is one of those territories up at the top, right there, if you can see that, and northern Ontario, who fly fly the kids down to be cared for. We have 167 beds. Sorry about that, and about 7,000 admissions a year. And we have about 180,000 ambulatory visits in a year. So we are what I would say is probably a small to medium-sized children's hospital, and we serve a very vast geographical area. So the Department of Genetics includes both the genetics clinic as well as the genetic diagnostic laboratory. And in our laboratory, we have both molecular and cytogenomics. Just to give you an idea of the size of the department, we have a director and 2 managers. There are 10 geneticists, 20 genetic counselors, 7 PhD clinical laboratory scientists who sign out of all of our reports, about 50 laboratory staff, 22 admins and clerks, and we run 2 training programs with about 7 to 8 learners at any given time. So when we started to think about how we wanted to do something with our electronic health record, what we really wanted to do was begin to think about how to equip frontline providers with tools that would enable diagnosis and referral. And really, we were trying to address the challenge that families share with us, that the diagnostic odyssey, this long, continuous bumping from place to place, trying to understand what's going on with their child, is exhausting. And so we started to think about an expert system that we could use to really identify the group of rare disease patients that are complex and undiagnosed. So around 2019, we met Ivan. There he's shown on the left. And the hospital, our institution, was having this competition, which was like a Dragon's Den type of thing, where you had to make a video and pitch something really out there to them to potentially fund. So this group of us on the right there, you can see we've got Caitlin in a hat and she's carrying an axe, and we've got Gabrielle over on the right side looking like a detective. We made this entire 2-minute video, which I was going to show you, but then I rewatched it today and said, maybe I won't, because it's a bit corny. And we pitched it to the powers that be in an effort to do something really quite revolutionary, we thought, in terms of changing how we'll do this. So we got all that done, and then we were waiting, and we'd been through the round. Everybody was super excited, and guess what happened next? COVID came, and it all disappeared. And so we kind of got stuck there for a moment. But what we did then is we didn't let that stop us, but we applied for grants and we found funding a different way. And so we were managed to move through. But as you can see, this has been an idea that was conceived in 2019 when Ivan came and gave us a presentation at lunch about all the things this data warehouse could do, which I'd never heard of until that lunch. To now, it's been almost 6 years, and it's certainly slowed down by the pandemic and the limitations that we had during those 3 years with a lot of shutdowns. So we use the electronic health record, EPIC, which I'm sure lots of you are familiar with. It was implemented at CHEO at least partially in 1994, but most of the outpatient visits have been part of EPIC since 2015, and that's when genetics came on to EPIC as well. And the advantage, of course, there are all of these searchable data and some of these standardized variables. And then what happened in 2019, and why Ivan came to see us in our research lab, was that this data warehouse was actually starting to become functional, and they were looking for interesting things to do with data using this platform called Caboodle. And so we started to brainstorm about what could we do about rare disease patients and visibility. Is there a way that we could think about that in this context? And that's how it all started. So I'll just talk now about what we did after that. And I think the very first thing we did was develop an amazing team. And so we had clinical geneticists and genetic counselors, thinking about the provider and patient experience on the one side. And then we had Ivan and his team of data architects and database and machine learning experts, giving us, education where we're not experts in this area, and also, helping do all of the work on the background to help this come together. And this has been literally a, solid 4-year collaboration. And where we decided to start was starting with a rule-based expert system and making it really, when you see the algorithm in a few slides, you'll say, oh, actually that's pretty intuitive and not really actually all that complex. And we're building on that now with machine learning, but where we started was this rule-based system. And so we would take knowledge from an expert, which is the clinical group, and develop a set of rules of if and then that could then go into this data warehouse of all of these hundreds of thousands of patients, and think about what, identify them and think about sensitivity and specificity. And so the methodology, as I was saying, really started with analyzing the criteria that our Ministry of Health, which is our funder for the province of Ontario, and we have a population in the province of Ontario of about 16 million people. But as I said, we were taking that clinical criteria. They were saying this is what patients need to meet to be eligible for genomic sequencing. And that's really reflecting the complexity of those patients. And so we were taking that complexity set of criteria and trying to tease it down into something that we could use to develop this algorithm based on what data items we might have available that were easy to extract and were part of the data warehouse. The next thing we did was develop a gold standard cohort. And for that, we used 6 years of patients from CHIO who had received exome sequencing, and thereby, by definition, they were eligible for testing. And so the baseline population was 18 years of age and under, lived in Ontario. So we were not looking at the Quebec patients and the Nunavut patients at this time. No previous abnormal genetic test results, and had never been seen by oncology, rheumatology, or hematology. And we can get into the nuances of that, but basically those three specialties see lots of complex children that have multi-system involvement, often because of some of the treatments that they're on, and therefore we needed to exclude them because they potentially have a different diagnosis. And so we were looking for multi-system involvement, both by codes in the diagnostic list and the problem list, as well as by departments, and looking at how much they were using the system, and taking that together and seeing if we could use that to develop the algorithm. And so what happened next was took a couple years, 2 years probably, and we optimized the search algorithm. So we had our data set, we had our gold standard, and we used that and kept making different alterations, expert-guided alterations based on what we were seeing. So we went through 5 iterations of this search algorithm, which in hours is about 650 hours contributed by the data team, and 500 hours contributed by Alex, and he was a student at the time, and other student, Grace Ede, on chart review. Because when it flagged, when the algorithm flagged patients as potentially eligible, you then had to go in and see if they actually were. And so we were using that input and output to decide how we could potentially alter the algorithm to be able to be more specific. And so that was these modifications. And we were looking at, if you can just see there, C1 and C2, we were looking at the between the diagnostic ICD-10 codes that were captured for an individual patient, and where they were the intersection of C2, which is the number of departments that they've seen. And so this is what the algorithm, like if you just bring it down to something that's quite simplified, this is what it looks like. And so it's really essentially just a set of rules that are currently functioning. And the biggest set of rules on the left-hand side, there's 6 there, are the exclusion rules. And these are very important. So you have to live in Ontario. You have to be under 18 and not a fetus. If the patient was exclusively seen in any of those oncology, rheumatology, or hematology, then they were excluded. If they already have an abnormal genetic test result, they were excluded. If they've already been seen by metabolics or genetics, they were excluded. And if you have a diagnosis code in our exclusion list, then they were excluded. It's really Rule 6 that we spent the most time on, because when you look at ICD-10 as a coding system, which is our only option to use in Canada, we don't have ICD-11 yet here, we had to remove things that were going to be flagging too many people as a second meeting criteria 1. And so things like hypospadias, spina bifida, prematurity, cerebral palsy, those types of codes and all of those codes that are related to them, we had to go through and start to remove them. And that's basically most of what was happening when we were looking at these different versions. So then what you had to do was meet criteria 1 and criteria 2. So criteria 1 was you had to have 2 or more diagnostic codes related to developmental delay or intellectual disability, a congenital anomaly, having removed sort of the more common non-specific ones, Another congenital anomaly in a different category, low tone, seizures, or consanguinity. For any of those, you just needed to have 2 of them, and you needed to be seen in 2 or more departments. Again, indicating that these that you have are important enough that you're seeing other people. And this is what selected the output from the patients. So the project life cycle, started with a retrospective proof of concept study. And this ran from 2018 to 2024. And we looked at, I'll show you the results of this in a second, but these phase 1 and phase 2 were really done in the research environment. We had REB, Research Ethics Board approval for this, and therefore we were able to do lots of stuff with this type of like electronic chart review, essentially. Phase 3 is the clinical best practice advisory, and I'll tell you about that at the end. But let's start with the retrospective proof of concept. So the 6 years of patient input that we put in represented 376,000 patients. And from that, through its various filtering, we ended up through a long process, which I won't bore you with, but we can go into more detail if people have questions. We ended up manually making 56 notifications to the most responsible physician. And so that means we're sending a staff message within Epic that explains that their patient has been flagged by the ThinkRare research algorithm, and we would be very interested to see the family and genetics and offer genomic sequencing if the family was interested. Now, of the 56, so yeah, 28% were referred, and we found 2 things. One is that the kids that were being referred tended to be older. And that likely represents the fact that there was a lot of data in the electronic health record for them, as well as the fact that this was a retrospective cohort. And that a lot of our referrals, when we didn't receive one from the most responsible physician, the primary care providers, if they were faxed this information from our the primary care providers had a much higher likelihood of making a referral. So there were differences in the referral rate. And I think that literally has something to do with, the fact that the primary care providers were receiving a fax, and therefore there was a piece of paper instead of just a message. So I just want to give you 3 examples, really to look at the types of diagnoses we were making and the types of patients we were seeing. And so this is a 17-year-old boy, right? So again, the older end. And he had, you can see in the colors, the different departments that he'd seen: cardiology, developmental peds, ophthalmology, ENT. So I'd met 2 or more. And in black are all of the congenital anomalies or findings that he had. So heart defects, intellectual disability, eye findings, laryngomalacia, and dysmorphic features that I'm putting there, but he was never seen by genetics. And he had a pathogenic deletion identified at 17p11 that resulted in having 2 diagnoses from ThinkRare. One, Smith-Magenis syndrome, and the other Birt-Hogg-Dubé. So he was missing about 2 megabases of DNA. And this was really important because he was actually at the age where we start to screen patients with Birt-Hogg-Dubé for the adult onset cancers that are associated with that particular condition. So the impact was actually quite significant. The second example is also 17, and you can see on the right this this journey for this little guy since when he was born in 2006. And Alex made this wonderful slide. And at each of these sort of years along the path, you can see all the different specialists that he saw. He's an engineering student now, but you can see in the colors the different departments that he saw: cardiology, ophthalmology, ENT, and developmental peds. So you can see why he would have triggered the alert, and he has some couple of malformations and developmental delay. And so again, he came in and was seen, and he had a de novo pathogenic variant in CHD4, which is associated with Syfram-Heights-White syndrome. And this explained his history. but also was very important for him because of the 50% recurrence risk. As I said, he's an engineering student and he's going to plan family one day, in all likelihood. And so this was important information to him for him to receive at this time. And lastly, I just want to show you this family. And so this is a 9-year-old little guy, and he'd been seen by two neurosurgery and developmental peds. He had congenital hydrocephalus, needed a shunt, and had mild ID. And he had 2 brothers and a mother with similar features. And so he had trio whole exome sequencing, and he had a diagnosis of Chung-Jansen syndrome. And this was really important. I have a little video I'm going to show you in a second for the family, because it really more so impacted for them how they advocate for him and his visibility in society and in our school system. But I'll let them share it with you. This is going to work.
So at the appointment, we were sat in a little room where Anthony was sitting between mommy and I, and they told us that it was Chung-Jansen syndrome, which both of us looked at each other and like, we don't know what that is. What is it? So what is it? And since Anthony is more French than English, he listened in, but was not paying so much attention because he was playing with mommy's cell phone. And out of the blue, he just looked up and said, "Oh, that's why I don't understand everything." And he started to cry. And that's when mommy and daddy became emotional. Less questions, less stress, less blaming ourselves.
And just now daddy can go right now to the special school and all that, and not going like 3-4 schools.
So yeah, it would have put a lot less stress on Anthony. This research actually brought kind of a peace in our house. A little bit of blood answered many questions. So at the
Great. Okay, I hope that came through okay. But as you can tell from Anthony's family, right, that impact of just being able to understand and plan his support and not blaming them. Where we went from there after this retrospective cohort is think about, okay, what do we do next? And we came along this, the idea of a best practice advisory. Was always our intent to think about having a way where it could be triggered in the system that this patient may have a rare genetic disease. And so these BPAs are a form of clinical decision support. For those of you who work in EPIC or senior, you probably see them for various things. There's an example here on the right of hepatitis C screening. We often see them for hemoglobin A1Cs when they haven't had it done in the last 3 months. It triggers it up so that you can order it very easily. So they're pop-up alerts that guide the end user's actions and are reminders, essentially. They can be extremely effective when they're configured. And they're designed to remind people what to do, and you have to balance that with not taking them off, essentially. So what we did then was to look at setting up a silent best practice advisory. So this is still under our research protocol. And for all of 2024, we ran the silent BPA. And it was running, basically the ThinkRare algorithm would run every night on the data EPIC warehouse, the EPIC data warehouse, and it would flag potentially eligible patients and put them on a list. And then Alex and Caitlin would go through this list and manually send out the letter in the electronic health record to the most responsible physician to say, hey, ThinkRare has flagged your patient as maybe having an undiagnosed rare genetic disease. If they're interested, we'd be happy to see them. And if they didn't answer or didn't decline, we kind of did follow that up to say, okay, well, why not? And so we could understand how it was working in real time and look at both education as well as knowledge and provider satisfaction. And so the outcomes of the silent BPA were 25 notifications to a most responsible physician. So this is over a year's time. And it's important to put this number in the context of how many patients we think we're missing in a year's time that don't already get a referral to genetics. Because remember, if you've already been referred to us, it's an exclusion criteria. And so this time, with the more recent numbers for the cohort, 17 were referred, so we're up to 68%. And we saw them within 4 to 6 weeks or so. And again, similar diagnostic yield to the retrospective cohort, 66%. Now, what we did see now that younger kids were being referred, and a much higher rate of referral because I think the patients were more active in the system. But we still saw that the primary care physicians tended to be much better referrers than the specialists at CHEO. And again, I think that probably has to do with the fact that when the primary care physician was getting the notification, it was on a piece of paper and going into their chart, and so it was harder to ignore. And I want to show you one example for a patient that was flagged in this part of the silent BPA. And so this little guy here next to his sister is a 2-year-old little guy. He had 75 outpatient visits across 9 different outpatient specialties in the first 2 years of his life. So huge use of the system. You can see that he'd seen gastro, surgery, pulmonary, and neurosurgery for many things. His biggest issues being failure to thrive in his G-tube. And he had a Chiari-1 malformation. He was short, and we could recognize some dysmorphic features when we saw him. And he had a de novo heterozygous pathogenic variant identified in TFAP2B, giving him a diagnosis of CHAR syndrome. And you can see you can see him right next to a published patient with CHAR syndrome, and you can really actually quite see the similarities in the dysmorphism. But despite the fact that he had 75 interactions with our healthcare system at our institution, he'd not yet been referred to us, and so this family was very thankful that ThinkRare flagged them. And Alex was telling me the other day that when he was seeing some ThinkRare patients in clinic, that one of them came from who was actually referred to us by a primary care provider, came with one of the news articles that had been published in the newspaper last year when we launched this silent BPA, and said the family doctor told us that ThinkRare identified us, so here we are, and they came with that piece of paper in their hand. It was very, very cute. So what we're trying to do with the silent BPA is practice it, and along those lines provide education and knowledge translation, so grand rounds and other outreach to make sure that when it goes live as a clinical best practice advisory, people know what to do and accept that this is happening and not just another thing you have to click. And we wanted to evaluate the performance really, really carefully in a more recent prospective cohort to make sure that we were not going to overload a system, which I'm sure, as you're finding too in Australia, is already overloaded with lots of patients and not enough staff. Now, building a clinical BPA is not easy. So you really do need to do a lot of this outreach and education. You need to have and think about how that clinical flow will go afterwards, and understand who the BPA is going to show to, how often, and what you're going to do to get rid of it. Because again, you don't want to tick off your healthcare providers. So we decided that we would only display it to physicians and residents on the providers that can actually make the referral. And we didn't want all the other allied health getting extra BPA pop-ups. And this way we felt it was most likely to reach the patient's most responsible provider. And so it will act as a pop-up was the plan, and there'll be 4 different action items we thought one could take. You could place a ThinkRare referral. You could indicate doesn't meet clinical criteria, or indicate that the family declined and there was an other box. And I'll just show you what it looks like. So this is it here. This is what pops up now. And so you can say it's got some explanation as to, okay, the ThinkRare algorithm has identified your patient as maybe having an undiagnosed rare genetic disease. And it says, it gives an explanation of why the patient was flagged and potential reasons for false identification. Because again, the most responsible provider still needs to be the person giving some thought as to whether or not this is appropriate referral, and speaking to the family to say, is this something that they want? And then one can click on the order button, and you'll get a ambulatory referral to genetics, specifically to the ThinkRare clinical stream, which will allow us to sort of track things on the other end. And if they choose not to order, we do have an acknowledgement reason at the bottom, because we need to understand why that patient wasn't particularly a good fit. And it will only disappear, the BPA will only go away for that provider if they pick the reason. And so that's going to be helpful in terms of tracking to make sure no one's been missed. And then once they get to us in genetics, they are booked as a specific referral type. And we have monthly spots available for them, and they'll usually be seen by a genetic counselor and a geneticist within 90 days of referral and offer genome-wide sequencing. So as of March 6th, we went live, and then about an hour later, we turned it off. And that's because for the first 3 minutes, the version of the algorithm that was in production when it went live forgot the exclusion criteria for 3 minutes. And as a result, 40 patients were flagged, which were inappropriate because Alex was watching on the back end. We fixed that up and we went live again yesterday, and now it's working perfectly as we expect, but we're keeping a close eye on it. And we've given some thought around what if a patient is not referred when they should be. And a lot of this came up from discussions when we presented to the Research Ethics Board, and also we've had discussions with privacy and the Clinical Informatics Committee to discuss, what if that most responsible physician, or that they don't have a primary care provider, and there's a BPA on this chart, but nobody's actioning it. And so this, because of the importance of the diagnostic testing, we have been permitted to now take the clinical BPA and run it as a quality improvement project, keeping an eye on the back end of it, so we can ensure that no one is missed. Because our Research Ethics Board actually had some concerns about the patients that didn't get referred to us in the retrospective cohort or in the silent BPA. Suggesting that possibly at some point in the future, we may need to think about a different way, or at least notifying the families directly that, this algorithm has identified them. So we are keeping a close eye on that, so that we'll be able to potentially take a couple of extra steps to give the family the greatest chance to be referred if that's appropriate and if that's something that we want. Because there can be a lot of reasons why it might get missed, including the encounter that finally made them eligible. It flags that night. The next morning, that clinician hasn't looked at that chart again, and may not for 6 more months. And so no one's seeing that BPA. Or they accidentally close the BPA without referring the patient, or the provider feels the patient doesn't meet criteria, but maybe they actually do. That's probably less likely to happen. People tend to refer versus not. But either way, we want to make sure that we give every family the opportunity. Now, with respect to improvements to the algorithm, there's a couple of things. We've just started adding additional machine learning models on top of the existing system, and our early data is showing that that's further improving the sensitivity and specificity. So that's going to be an exciting thing to keep working on in the back. And the other thing that I think is very important for people to understand is that ThinkRare right now focuses on complex genetic syndromes. It does not focus on single system diseases. So if you have a renal difference or an eye difference, like a retinal dystrophy, and that's the only thing, you are not being flagged by ThinkRare. If you have an autoimmune disease that's genetic, with a genetic contribution, you are not being flagged by ThinkRare. And so you can imagine there could be other ways to develop similar algorithms to look for patients that have single system disease that may have a significant genetic contribution and would be eligible for genetic testing. And finally, I just want to wrap up with what we're thinking about with respect to dissemination and expansion. So we learned a few lessons that we want to share with people. And I think the first is that a multidisciplinary team is required to support developing the algorithm and the tool. You have to have engagement from your data experts, and you need the same amount of clinical engagement, and you have to work as one team for sure. The second is the algorithm is only as good as your data. So the quality of data within your electronic medical record be good, and any mistakes that come in or missing pieces of information, all of those can mess with your algorithm and cause false positive flags. So there has to be a lot of education to providers about making sure they submit quality information when they're closing their charts. Third, every time you deploy this algorithm in a different environment, the sensitivity and specificity will likely have to be optimized for that environment and the context of what's happening there. So it's not just like taking what CHIO has done and moving it completely the same way to the next place, because their mapping and their coding is going to be a little bit cultural to their environment. And so you have to make sure that that specificity is still very high, because we cannot open the door to a floodgate of inappropriate referrals in the context of already busy service. And the last thing is that a well-resourced clinic is essential. So if there's already, really long wait lists and you're just adding to that, is will just happen before they ever get anywhere near their specialist or the geneticist. We've had we had a little bit of press around this when we first launched this in Rare Disease Day last year, and so definitely there are other institutions. So we're working now with Alberta Health Services, which services the whole entire province, and kids who want to bring that in and are also on Epic. And then there are institutions without Epic but use CNR, like BC Children's, who really want to give this a try. And even though this was all just sort of Canadian news, lots of international people have reached out to us as well, because they're interested in thinking about how this might work at their institutions. So we've been, engaging with all these groups and trying to provide all that we can. Because what we want to do is make this available to everyone without any sort of things that could set up barriers. And so we have we are applying for the official trademark ThinkRare for Canada, and we put a provisional patent application on so that we can the method to ensure that we can make it freely available and that no one could come after us and commercialize it and then try to sell it to people, because that would be against what we're trying to do, which is trying to improve visibility for rare disease patients and making it accessible to everyone. And there is some philanthropy and pharma that have become quite interested in supporting dissemination in Canada. And so we'll likely use some of those resources to help the other hospitals in the different areas do a little bit of the work they'll have to do to make sure their specificity and sensitivity are optimized. So with that, I would like to just say that this has been a very exciting 5-year project that we've taken off. It's wonderful to see that it's come this far, and none of this work could have been done without this amazing team. Alex and Sarah Sawyer, she's a geneticist. Caitlin Chisholm is on today. She's a genetic counselor, and Grace, who's now a genetic counselor at UCLA, who was training with us when this all started. And then Ivan is on today as well. And again, he's led this whole informatics team, Nicholas, Jeff, and John, who have been amazing at trying to help us, take this sort of rather simple concept and make it so that it's a computer readable simple concept. And it's wonderful to see that we're finding these patients that otherwise would have been lost in our system for at least longer than they have been now. And eventually, we've actually had one flag now that has flagged a kid who's as early, a baby who was 10 months old. And so we're getting it further and further, moving it forward in their diagnostic care pathway. And that is very satisfying, I must say. So with that, Tiff, I can maybe stop sharing and take some questions for about 10 minutes.
Excellent, Kim. Thank you so much. It's so exciting to hear that ThinkRare went live yesterday after the sort of fine-tuning a bit. So it's a very timely
Fine-tuning. It's pretty funny. I got a text from Alex at night. We had to turn it off.
But I do want to see that corny pitch video it's on stage, so maybe we can do that offline.
Yeah, offline. I'll send it to you.
All right, beautiful. The way that you describe the development of the algorithm and the importance of the multidisciplinary contributions to that, it does seem like a very sort of intuitive process, but clearly a huge amount of work. I did have a question about the exclusion criteria. So, you mentioned that if the patient's deceased at 0 days or a fetus, recognising the significant value of genomic testing in a prenatal setting or in genomic autopsy, is that reflecting Ontario Ministry of Health guidelines for eligibility or?
No, it's not. Our fetuses are eligible for genomic testing. The thing about, so again, it really needs to be contextualized to the local environment. So at our place, we see every single prenatal person undergoing amniocentesis or CBS. So we have complete capture. So we don't really need to find those most fetuses. And then the other challenges around fetuses is the lack of information in terms of they wouldn't meet the criteria, right? Because they haven't seen departments. And they may have been coded with respect to their problems, but often not. So it is just a different group in terms of how you would optimize for that particular cohort.
Okay, understood. That's very clear. All right, we'll start with some questions on the chat. So Chris, thanks you for the presentation, and emphasises that early diagnosis is important for children with genetic disorders that cause dementia. So Chris is from the Childhood Dementia Initiative.
Oh, wow. Okay.
Did I understand correctly that you excluded patients who'd seen metabolics? And if so, why is that?
Because metabolics and genetics are almost interchangeable at our institution, and so it's the same group. And as soon as you've seen metabolics, you have access to the same testing, and they would have had genomic sequencing with metabolics.
All right, that's clear. And would that be the case in other centres that perhaps are adopting the tool, or would you need to tweak the algorithm to ensure those patients are also captured?
For Canadians, it would be mostly the same.
All right, excellent.
Yeah, we're very interlinked with metabolics.
We also have a question about, I see there's been efforts to begin utilising the tool across Canada. I wonder if there's any potential to expand it to be offered in the adult setting for those who may not have been diagnosed as kids.
Yeah, again, I think that it's something we've thought about. And we actually see adults at our children's hospital in genetics as well, but we do not run the algorithm on the adults because within their CHIO record, there's not enough data points to make the algorithm in its current version work. So we have had people who work at more community-based hospitals that have genetics in Canada ask us about this. And the challenge with the adults is the huge amount of acquired disease that looks like genetic disease. And so theoretically, I think one could think about that at some point in the future. But if you were going to tick off things like, neuropathy and renal failure, I mean, they could just all be related to diabetes. So you would have to build it for the adult population and work on your specificity and sensitivity in a different group.
Yeah. Okay. We also have a question about how you implement AI in your project.
Oh, yes. If Ivan's on, he can answer that. Will, can you give Ivan, I think you're going to search his name up. Yay, there he's coming.
Hey there. Can you guys hear me?
Yes, yeah, we can hear you.
Okay, so basically at the time that we started developing the project, the AI techniques at the time really struggled with unbalanced data sets, and that's why we kind of went the expert system path, and that's yielded the best results for us. And so by the time that we were kind of already down the road and the AI techniques evolved, we hear about ChatGPT and all these other great things happening all the time. We were already kind of at the point where we had a successful algorithm identifying patients that we wanted to kind of get to that implementation phase, but now we're kind of going back and applying some of the new, more modern techniques onto, like, in kind of an ensemble fashion where we're combining the outputs of multiple models in order to improve our model performance.
Excellent. Thank you, Ivan. I've got a question also about, you mentioned that as, you know, in the context of the plans for dissemination, that facilities adopting ThinkRare would also have to sort of do some tweaking of the algorithm for their sort of data set and circumstance, etc. Have you had to engage, like what sort of estimates are you providing those facilities about the type of investment, how long it'll take, resourcing required, etc.?
Yeah, we have actually started to develop that TIF, which, and I'll let Ivan comment on that in a second as well, because we've had some recent discussions with Alberta. So that's our first test case of bringing it across to a different province and a different jurisdiction that have a different way that their data warehouse works, right? And so we have sort of set up a minimum set of things you need to do. So it's not going to take 5 years for anyone, but we do estimate it would take 6 to 9 months to actually optimize it and get it working. So it's a reduced time, but it still requires some input. And Ivan, do you want to comment on our discussions with like some of the considerations that the Alberta group had?
Yeah, for sure. So, you know, to actually transport this into a different center would be a lot of pretty unglamorous work by the database people, essentially looking at the data elements that we have at the CHIO system. You know, how do they map to what the target site would have? You know, how are things coded? You know, for some of the exclusion criteria, we literally are identifying not a diagnosis code, but an actual specific diagnosis in the database. And then we would also have to go through their department lists, understand their clinical structure and how their clinics work. And so some of the departments you saw within the criteria are actually kind of grouped together. So we have neurology and neurosurgery. They're all kind of like treated as one specific department, even though there are multiple physical departments in the hospital. So a lot of that work would have to get done. So I would say mostly on efforts on the database side, where the kind of the technical folks are going to be doing some of those checks and balances, but also a fair bit of validation, kind of chart review work that Kym also mentioned, that, you know, having gotten an output from the, you know, first run of the algorithm, okay, let's go check if it's actually working. You know, that still takes quite a bit of time and resources.
Great, thanks, Ivan. We've got a few questions coming in now. So one asks about eligibility criteria again, and, you know, sort of that, is there data showing that these criteria miss many patients who might benefit from genetic testing? I suppose this was in your pilot phase. You did these analyses.
Yeah, totally. That's a really good point, right? Because we have a crazy diagnostic yield. That's insane. It's like 65%, which is unheard of. And so obviously we're super specific. So, but again, we had to set it up in our environment like that. So it's a screen, but it's a very highly specific screen that we're doing on the general population of the hospital. So you trade off when you do that, right? You trade off. And so we will miss people because of that. And we have to hope they get to us in a different way, because we can't flood the system with 75 inappropriate patients to get 25 correct patients. So it's not ideal. And I think as things evolve, you can start to play with that and change the specificity and the sensitivity a little bit to decrease the chance of getting false negative flags.
Yep. Okay. I did choose the question. Now this is challenging. Joseph asks a question. So is there anything in common or more common among the patients that have been flagged by the BPA for consideration for genetic testing, which could suggest systemic issues in selecting them for testing in the first instance? Perhaps there could be, for example, cerebral palsy, which is 30% genetic, but not everyone would believe so and order a test.
Yeah, so there's a couple things. That's a great question, Joseph. I think when you think about systemic issues, it's confusing, right? So for the retrospective and the silent BPA, why aren't they getting referred? So for those that didn't come, like the 70% that didn't come for the first retrospective, or the 40% that didn't come from the silent BPA, are they coming because of social determinants of health, where they're just not accessing the system correctly, et cetera, et cetera? So, but I think what Alex and Caitlin would say in terms of what they've seen in the clinic is all types of families and patients. You get some whose parents are family docs and had been asking for a referral for some time and didn't get it until ThinkRare flagged on them. And then you'll have some like Anthony's family, who would have had a harder time working through the system. No, they're French. They're coming into a bilingual hospital, but still it's not as great as it should be for French patients. But they managed it. And so there are definitely some that don't get to us, I think, in my mind anyway, because they're just not as interested in a diagnosis. So maybe that's why they declined it way back when and didn't come. But we don't have any specific evidence that that's actually the case. It's just sort of what I'm thinking.
I think too, I mean, what I find inspiring, Kim, in this talk is thinking about potential for these sorts of algorithms beyond the clinical setting, and also in terms of health system evidence development for health system costs, family impacts. I mean, the videos that you showed really, demonstrates the potential, sort of transformative impact on families of a diagnosis. But, I'm thinking health technology assessment, system utilization type evidence. I think there's so much potential for algorithms such as this in other settings as well.
I totally agree. And this is not even really AI, right? It's baby AI at best. It's an expert-based system with some machine learning that's going to further develop it going forward. But you can just imagine where we'll be in 10 or 20 years with being able to do something even more sophisticated, right? This is pretty simple, which is what's actually beautiful about it. So it is transportable and it finds patients that we're looking for. So that's great. But you can imagine if we could actually read the notes. We have thought about that, right? Can we actually pull out clinical information from the notes and use that as part of the machine learning, and then all the other things you could do with respect to what happens with those families afterwards.
And that would be dependent on patient and societal comfort with the use of those sort of tools. Oh, Ivan, you've got a question.
Yeah, just wanted to comment. As we think about increasing the sophistication of some of the techniques that we're using to identify the patients, that makes that a transportability problem so much harder, because a lot of what's required to deploy something like this, once you have an algorithm that's trying to, compute things in, near real time, all of a sudden you need all this infrastructure to actually do that. And some of the, technical capabilities of hospitals that might benefit from this, they might just not be there. So actually having this as a rules-based kind of expert system makes it a lot more transportable, but also a lot more, it gives us a better ability to adapt to different systems. It doesn't really matter if you have Cerner or Epic or Meditech or any of the other EMRs, we could still deploy it there.
Thanks, Ivan. I'm sort of grounding my aspirational thoughts about where we can go with this with your technical perspective. Look, we are at time. Kim, thank you so much, and Ivan and your team for joining us today. I'm sorry to those of you whose questions I did not get to. It's been a really fascinating presentation, Kim. Thank you.
Thanks, everyone. Nice to see you.
And thank you all for joining us for DNA Dialogue today. Due to public holidays, etc., in April, we'll be convening for our next webinar on the afternoon of the 21st of May. And I'll be joined by Dr. Eva Maria Coutiongo de la Paz from the University, I'm not sure which university in the Philippines, that was silly, but she will be sharing her insights on investigating genetic epidemiology of X-linked dystopian and Parkinsonism. So please reach out to your favourite neurologist and spread the word, and we look forward to seeing you there. Thank you.